Welcome to Let's Talk, straight talk, hard topics, smart people. I'm Stephen Graves, and I'm here at the SNMMI conference here in Toronto. I'm talking with Dr. Robert Hobbs. Welcome, Robert.
Thank you.
In terms of widespread adoption of dosimetry, so if you mentioned that we can get much closer to appropriate treatment levels if we customize, despite 20 to 30% uncertainty. So that sounds promising, but what are the main barriers to widespread use of dosimetry routinely and in clinical practice to actually modify patient care?
Yeah, so that's kind of a loaded question because the barriers have evolved a lot over the last 10 years. When people just coming up with, reasons to not do it, to really thinking about what are the serious problems that we're encountering if we tried to do this. And, some of the barriers have been overcome. Some of them are being negotiated. And then, of course, it all depends on your perspective.
So give us the good news. So what are some things that we've overcome? We certainly have more software options now. I mean, including our hosts here at Voximetry, but among others, we have, a relatively significantly more diverse array of tools at our disposal, right?
And I think, for example, the inconvenience factor is being played down more. When people realize that the potential benefit, because for a long time it was like, oh my goodness, the patient is going to come in and we're going to have them come back for 3 days in a row to do dosimetry, and oh, this is such an inconvenience. But it was always from the perspective of diagnostic nuclear medicine, where patients come in once, it's a single diagnostic, and then they go home and it's not a problem. But it wasn't from the perspective of radiation therapy, where, for example, an external beam, they might have to come back for every day for 5 weeks. Yeah. And, when it comes down to it, if I know, and if I were being treated, or if one of my loved ones were being treated, I would say, take the extra 3 days, do the dosimetry, and get the better treatment. Yeah. And people are starting to realize, and the potential benefit is starting to be valued more. And so they're starting to say, oh, we're going to weigh the inconvenience against that potential benefit. So I think people have better understanding from that standpoint now.
So in regard to patients having to travel very far to get their scans for dosimetry, I think that somewhat relates to the catchment of what your patient population is that you're treating. Meaning, if you're at a center that is skilled in neuroendocrine tumors, which is a relatively rare condition, you could have patients coming from out of state, flying in from other places, and in that case, it is relatively inconvenient for them to stay multiple days. But if you use something like prostate cancer, where you have more sites that are developing capacity to treat patients and do dosimetry, the catchment is a little bit smaller. Maybe they don't have to travel as far. But what do you think about a model where physicians that are the treating physician can look at a map of SPECT CT scanners near the patient's home, and maybe they could go and get scanned there? So that sounds like a good idea, but as a physicist, it makes me nervous.
Yeah, absolutely.
So what do you think?
I understand. And that goes to one of the things that we haven't solved very well, which is going back to, the uncertainty factor. And we were only talking about theoretical uncertainties. And what we're realizing is that there are the theoretical uncertainties, and then there are the practical uncertainties. There are the workflow, errors and mistakes. And what we really need to overcome, coming back to the second question of what we need in order to be able to implement this, is much better quality assurance and standardization. So that, because we did have, back in the 2000s, Bexar was a dosimetry-based, personalized dosimetry-based therapy, but it was very simple. It was designed to be, foolproof. They had 3 planar images, which anybody can do. They didn't do any dosimetry on any of the organs, so there was no contouring, there was no registration. And so there was just a whole body as a surrogate for bone marrow toxicity, which was what the toxicity was. And that worked fine, because the spreadsheet was designed to be just filled out, and it was perfectly good. So we need to find obviously we can't have that kind of simplification. For one thing, obviously we don't want to use planar imaging for anything that's, 3-dimensional for organs or for tumors, but we need to find a more happy medium between, here's the whole realm of what you could do with dosimetry, pick and choose, and that be able to guide people and say, in this particular situation, this is the best option, but also provide them with the kind of quality assurance that we have, for example, an external beam. both kinds, like the TG142, which is based on, the number of numeric values. When you test each component of your dosimetry, you should be within 5% on this, you should be within 10% on that, you should be within 2% on this, but also the TG100, which is more about workflow and process, which is where are your errors going to occur? Right. Where are you going to make mistakes? How do you have double checks?
The likelihood of an error, the severity of an error, how likely it is that you would discover an error before it reaches a patient. All three of those are factors to consider when setting up quality assurance workflow for RPT dosimetry, right? I want to go back. You mentioned Bexar, which is very interesting. So in this case, it's an estimate of whole body dose, which is a surrogate for bone marrow dose, which is what we actually physically think about as being related to cytopenias and toxicity from radiopharmaceuticals. Is that that surrogate approach, is that viable in other ways? So for example, alpha emitters, the interplay between the alpha emitter perfusing the bone marrow may be very complex. So should we just be relying on dose to blood or some very simple surrogate for bone marrow dose for something like an alpha?
I think that's not necessarily a bad approach. It goes back to our first question of what is the uncertainty? And, are you going to get something that's maybe more accurate but less precise and certainly less complicated? Right. And so maybe the trade-off is worth it. If you can get something that's within 30% using a simple blood or bone dosimetry for alpha particles, rather than trying to do something very complicated that technically could be more accurate, but is much more difficult to accomplish, that's probably not a bad idea. I mean, you would have to take a look at the specifics, but I would think that would certainly be a viable approach, certainly as a place to start, and then examine whether it's worth moving to something, again, more complicated, possibly more precise and accurate. Yeah.
So in terms of other barriers, one of the initiatives that we were sort of jointly working on is education. So I think, historically, nuclear medicine has had a large role in some of the more complex unsealed therapies. Community practice radiation oncology clinics have been doing radioiodine for thyroid cancer for a long time. How do you see training as being achievable or not achievable, and how important is it? As a nuclear medicine physicist primarily, I'm acutely aware that we only have maybe a few hundred qualified medical physicists in the nuclear medicine field, and with the way things are going, just looking around the vendor hall here at the society, there's going to be a lot of new agents coming in the next 10 years. How do we get ready?
Right. So those are complicated questions, and I think there are two parts to that question. The first is you pointed and you switched from education to training, and I think it's important to make the distinction because we're realizing. I think it's very important to realize that we need more training, but not necessarily more didactic education, because when all of a sudden radiopharmaceutical therapy started to become a big thing again, the MERD committee, the IAEA, the ICRU all got together and said, we got to write this big book to explain to people how to do dosimetry. Sure.
And then you end up with a few books.
We have, as far as I know, there are 4 of them out there, really big ones that explain how to do dosimetry.
And then we did the summer school and we wrote another book, right?
Exactly. That's one of the ones I was talking about. Exactly. There was a summer school book as well. But the point is that when SNMMI did the dosimetry challenge, and when the IAEA did their dosimetry CRP, and took people and said, let's do dosimetry together and see what the variability is, we realized that there's a huge variability of results. And that goes to the problem of QA, and it also goes to the problem of training. And it's remarkable in SNMMI, where it was a bunch of people who thought that they were good at dosimetry, and some of them probably are. And so we're not sure whether it's personal choices and say, I want to do the dosimetry this way, or if it's just a lack of quality assurance. And we don't know for sure. But certainly in the IAEA, what we saw was, we're not just telling people how to do this and then they go away and they do it properly. It was multiple iterations of in-person
lots
training.
Of hands-on training.
Exactly.
Right.
So I need more of that. We definitely need maybe less didactic material and more training. So that is absolutely one of the things.
So we have plenty of didactic material from which to pull to educate in a graduate program and a residency. But to what extent is that enforced by accrediting groups? In CAMPEP and ABR, they don't really encourage programs to cover this at this point.
Yes, they don't. And again, there's going to be a difference in opinion in who should be doing this, which, is also part of the question of what are the barriers, because not all societies, not all groups view what the barriers are, because we don't all have a common goal, a common vision of how all of this is going to come together. And we kind of have, but it's fairly nebulous, and some people are more on one side and some on the other, and there are definitely variations in there. And to go back to one of the problems that nuclear medicine has with the the lack of physicists, what I hope is, and I think this also goes to one of the other barriers, which comes up often, is the lack of spec CT machines. Because if, we're going to be doing this on every patient, then we're going to need a lot more machines than we have. And it's kind of like, hopefully it's displacing the entire paradigm together. Once we see the potential benefit that this can have, there should be more investment and understanding and reimbursement and money available for spec CT and physicists in order to help grow the whole industry, So hopefully it won't be limited because of that. It's not like nuclear medicine is going to say, well, this is the number of physicists we have, and oops, well, that's all we have now, so we're not going to be able to do it. At least I hope not. I hope this will, help grow the number of physicists they can recruit.
So there are a number of stakeholders. I mean, we have nuclear medicine technologists, we have radiation oncologists, nuclear medicine physicians. So physicists are one key player, but there are others. So paint a picture for me of what it would look like if we had an insufficient number of physicists out practicing to support the general clinical practice of radiopharmaceuticals.
Right. So I think there are two different solutions that will help tremendously. And one is the more nuclear medicine solution. The other is more radiation oncology solution. The more nuclear medicine solution is to make use of the people you already have, which are technologists, right? And so you can say, the technologists can do the dosimetry. Now, as physicists, that scares me a little bit, and I think it scares a lot of physicists, but we have a similar paradigm in radiation oncology, where we say the dosimetrists are going to do, the treatment plan. And it works quite well.
But they go through a very specialized training program to get that role in radiation oncology.
They do. And at the end, it is still physicists that check and make sure that everything's okay. There is always physicist oversight.
And not just oversight, but redundancy and independent verification of the calculation.
So the redundancy and independent verification and the double checks and the checklist, that all goes to the QA. Absolutely, that can be part of the process. But in terms of the personnel that is involved, so obviously, in order to make this work, we do need, again, all these QA things that are needed. Absolutely, that's one of the major barriers to make sure is, and they need to be, all these processes, regardless of the personnel that's doing it, needs to be in place. But one of the people that needs to be there as a redundant person has to be a physicist, has to be a medical physicist. So that means that the medical physicist isn't doing everything and can delegate a lot of the work, but at the end has to be supervised. And then the other option is just to work with radiation oncology, because there are a lot more physicists in radiation oncology, and they have more of that QA expertise. They have more of that redundancy, double checks, checklist type of mentality that could benefit. So I think I really hope this is going to be the way forward in most institutions. They're going to say, we need a radiopharmaceutical therapy or theranostics, center, where we bring and we pull the resources from the different, departments that know what's going on, nuclear medicine especially, radiation oncology, and maybe medical oncology. Together, we figure out how to make it work. And that would certainly, one of the things that radiation oncology could bring to the table is more physicists. But again, hopefully in the long run, will ABR decide to, or CAMPIP decide to say, we're only going to put radiopharmaceutical therapy in the nuclear medicine track, or are we going to put it in the radiation therapy track? So we actually have a master's program right now, and we're developing a PhD program. And our idea is, well, what are we going to bring to the table that's special? Well, radiopharmaceutical therapy. So what we do is but there's no radiopharmaceutical therapy track for the ABR. So what we do is we give people enough courses in both nuclear medicine and radiation therapy that they can choose one or the other, but they're going to have that subspecialty and training in radiopharmaceutical therapy.
Yeah, that's great. And on that note, I've been talking with Rob Hobbs, and this has been a great conversation. Thank you so much for your time. Let's talk again soon.